Welcome back to the deep dive. Today we're getting into a system that, well, it runs your body's entire economy, it manages toxic waste, and it houses a huge chunk of your immune system. And yet, most people only think about it when they're reaching for an antacid. We are talking about the gastrointestinal tract.
It's arguably the most complex interface between you and the outside world.
And that makes it really high-stakes territory.
Mhm.
We are working from a bit of a heavy hitter today, gastroenterology. Clinical cases uncovered by Sadish Keshav and Emma Culver.
Right.
And this isn't just a biology review. It's more like a manual for clinical detective work. So our mission is to take you from, my stomach hurts, to really understanding how a specialist tells the difference between a dietary issue and a life-threatening emergency.
That is the whole crux of it. In GI medicine, the symptoms are often so vague, pain, bloating, nausea. The deep dive here is learning how to filter all that noise to find the actual signal.
So we're building a mental toolkit.
Exactly. We're going to build that toolkit to diagnose the gut, starting from the mouth, going all the way down, and then we'll hit the body's chemical factory, the liver.
Okay, let's start with that toolkit. The book makes a pretty bold claim that the most sophisticated diagnostic tool isn't, say, an MRI or an endoscope. It's the conversation.
It's the history taking, 100%. Because the GI tract is, well, it's a long tube with organs attached, so the specific nature of the symptom tells you the location.
Okay, give me an example.
Take swallowing. If a patient just says, I can't swallow, that's too vague. You have to distinguish between dysphagia, which is that physical sensation of food sticking.
And obstruction.
Sorry, an obstruction. And odynophagia, which is actual pain when you swallow.
So one implies a blockage, the other implies inflammation.
Precisely. And this leads us to probably the most critical concept in the whole book, the alarm symptoms, the red flags.
These are the things that take a patient from wait and see to get this investigated now.
Exactly. The non-negotiables.
I think we should list these out because this is just such high-yield knowledge. The book lists 5.
Right. So number 1 is progressive unintentional weight loss. If you're losing mass without trying, something is consuming your body's resources, often a malignancy.
Okay.
Number 2, progressive dysphagia swallowing that gets worse over time. Number 3 is persistent nausea or vomiting.
And the last 2 have to do with blood.
Yes. Symptomatic GI blood loss, so that could be vomiting blood hematemesis or passing black Tory stools, which is melena. And then the last one is unexplained iron deficiency anemia.
That last one is interesting because you might not actually see any blood.
Not at all. But your blood count is screaming that there's a leak somewhere. It's a silent alarm.
So once you have the history, then you actually touch the patient. Inspection, palpation. I've always found percussion tapping on the belly a bit abstract. Does it really work?
Oh, it absolutely does. If you understand the physics, you're tapping to hear resonance. Gas sounds like a drum. Fluid or a solid mass sounds dull. So if a patient has a belly full of fluidocytes, you can literally hear the dullness shift as they roll over. It's a bedside physics test telling you the liver might be failing.
Let's apply this detective work. Upper GI tract. Case study. Mrs. Sarah Whiston, 61. She comes in with progressive difficulty swallowing solids.
So right away, you have an alarm symptom. Dysphagia in a patient over 55.
This is cancer until proven otherwise.
It has to be. But clinically, you first have to distinguish between a mechanical blockage and a motility issue, a problem with the muscles.
And how do you do that without putting a camera down there?
The history again. With a mechanical block, like a tumor, you get progressive dysphagia. Solids stick first because the pipe is getting smaller. Liquids are fine at the beginning.
But eventually nothing gets through.
Exactly. Whereas with a motility disorder, like achalasia, the pump has failed. The muscles that push food down don't work, and the sphincter at the bottom won't relax.
So not the size of the hole, it's the pump itself.
Right. So solids and liquids are difficult from day one.
In Sarah's case, they did a barium swallow. And the images for these two things are, well, they're starkly different.
They are. A cancer often looks like a rat tail, a jagged, irregular narrowing. Achalasia looks more like a bird's beak, a smooth taper with this huge dilated esophagus above it where all the food is just piling up.
And Sarah had the rat tail, esophageal cancer.
Which just shows why you can never, ever ignore progressive difficulty swallowing.
Okay, let's look at something more common. Chest pain. Case 2, Fred Drunson, 52. He has chest pain. As a GI expert, is your first thought esophagus?
No, my first thought is heart. You always rule out the cardiac killer first. The nerve supply overlaps. But once the heart is cleared, we look at Gorgie gastroesophageal reflux disease.
But Fred didn't just have heartburn. He had something called water brash. Can you explain that?
It's a reflex. Acid comes up the throat. The body senses this change in pH and it panics. It just floods the mouth with saliva to try and neutralize the acid. So patients describe a sudden rush of salty fluid.
And he also had a cough at night.
Exactly. He's aspirating tiny amounts of acid while he's lying down. Management for this is lifestyle weight loss is huge, and PPIs, proton pump inhibitors.
So how do those drugs actually work on a cellular level?
Well, they bind irreversibly to the proton pumps, the hydrogen-potassium ATPase system in the stomach lining. They just shut down acid production at the source.
Let's move to case 4, Graham Clow, 36, upper abdominal pain. And this is where we meet the rock star of the bacteria world.
Helicobacter pylori.
This is a fascinating story. We used to think ulcers were from stress.
We did. Stress and spicy food. And then we found this spiral-shaped bacterium. It's incredibly evolved. It burrows into the stomach's mucus lining to hide from the acid. It even creates its own little cloud of ammonia around it to neutralize the immediate environment.
And that causes inflammation.
Chronic gastritis, which leads to peptic ulcers and, over a long time, a much higher risk of gastric cancer. And Graham didn't need a scope. He did a carbon-13 urea breath test.
Okay, break down that chemistry for us. It's so clever.
It really is. You drink a solution with urea that's been labeled with a special carbon isotope, C13. Now, H. pylori has an enzyme called urease, which humans don't.
Right.
If the bacteria is there, it breaks the urea down into ammonia and carbon dioxide. That CO2, with the C13 tag, gets absorbed, goes to your lungs, and you breathe it out. We detect it in the breath.
That's elegant. And the cure is just antibiotics.
Triple therapy. 2 different antibiotics plus a PPI to keep the acid down so the antibiotics can work. It has a very, very high cure rate.
Okay, let's head further down the track. Part 3. Lower GI, the intestines. This is where bleeding patterns become a huge clue.
The rule of thumb is simple. The darker the blood, the higher up the source.
So it's bright red.
It's fresh. It's usually anorectal hemorrhoids, a fissure, or maybe the very end of the colon. But if it's black, sticky, smells like tar, that's melena.
And that means it's digested blood.
Exactly. Digested by stomach acid. That tells you the bleed is high up, probably the stomach or the duodenum.
Then you have the silent bleed. Case 13, Mrs. Irene Pale. Elderly, tired, looks pale. Iron deficiency anemia, but no visible blood.
This is a major takeaway. For any student listening, an elderly patient with iron deficiency anemia has colorectal cancer until you prove otherwise. Specifically, right-sided colon cancer.
Why specifically the right side?
It's all about anatomy. The right side of the colon is much wider, and the stool there is still liquid, so a cancer can grow quite large without actually blocking anything.
So it just sits there and bleeds slowly.
Exactly. You don't see the blood, it just mixes in, but you're losing iron day after day. By the time it's found, the patient is very anemic.
Then on the left side.
The left colon is narrower, stool is solid, so a tumor there causes a blockage, constipation, pain much earlier.
Speaking of flow, let's talk about diarrhea. Case 9, Emma Ritchie. Chronic loose stools. The big challenge here is telling the difference between IBS irritable bowel syndrome and an organic disease like coeliac or IBD.
Right. IBS is a functional diagnosis. The gut looks normal. Organic disease means there's visible damage.
Let's start with coeliac disease. That's an autoimmune condition, isn't it?
It is. When someone with coeliac eats gluten, their own immune system attacks the lining of the small intestine. The book uses a great analogy of a shag pile carpet.
Right, because the healthy gut has these finger-like villi to absorb nutrients.
Exactly. In coeliac disease, that immune attack flattens the villi completely. You go from a shag carpet to a tiled floor. You lose all your absorptive surface area.
Which leads to malabsorption, weight loss, diarrhea.
Then you have inflammatory bowel disease, IBD, Crohn's versus ulcerative colitis. People always mix these up.
What's the cheat sheet?
Think depth and location. Ulcerative colitis is superficial, just the top layer, the mucosa, and it always starts at the rectum and moves up the colon continuously. It never skips.
It's contiguous. And Crohn's.
Crohn's is the rebel. It can be anywhere from mouth to anus. It has skip lesions, disease patches right next to healthy tissue, and crucially, it's transmural.
Meaning it goes through the whole bowel wall.
The inflammation eats right through the entire thickness. That's why Crohn's causes fistulas and strictures, and UC generally doesn't.
Okay, let's leave the two and go to the factory. Part 4. The hepatobiliary system. The liver.
The metabolic hub. And when it fails, you turn yellow. jaundice.
Case 15 breaks jaundice down into 3 types, which is really helpful for visualizing what's gone wrong.
Think of it like a production line. Prehepatic is a supply problem. Too many red blood cells are breaking down, that's hemolysis. And they're dumping too much bilirubin for a healthy liver to handle.
All right.
Hepatic is a factory problem. The liver cells themselves are sick from hepatitis, alcohol, drugs, and they just can't do their job.
And post-hepatic.
That's a shipping problem. The liver made the bile, but the exit pipe, the bile duct, is blocked by a gallstone or a tumor.
And to figure out which it is, we use liver function test LFTs. They always look like alphabet soup on a lab report. ALT, AST, ALP. How do you decode that?
You group them. ALT and AST are enzymes that live inside the liver cells, so if they're high, it means the cells are bursting open. That's hepatocellular damage.
The factory's on fire.
Exactly. ALP and gamma-GT are enzymes that line the bile ducts. If they're high, it means the plumbing is backed up. That's cholestasis.
So the drain is clogged.
That's a crude but a very accurate way of putting it.
We can't talk about the liver without talking about alcohol. Case 18.
Yeah, alcohol is a direct hepatotoxin. We screen for it with the CAGE questionnaire. It's a classic acronym.
Right.
C, have you ever felt you should cut down? A, have people annoyed you by criticizing your drinking? G, have you ever felt guilty? And E, have you ever had an eye-opener in the morning?
And 2, yes answers is a big red flag.
A very big red flag. And if you don't stop, you can get cirrhosis. Scar tissue replaces healthy liver. Which leads us to case 17, ascites.
Fluid in the abdomen.
It happens for 2 reasons. 1, the scarred liver is hard, so blood can't flow through it. The pressure backs up in the portal vein. And 2, the failing liver stops making a protein called albumin.
And albumin is what keeps fluid inside the blood vessels.
It acts like a sponge. Without it, water literally just leaks out of the veins into the abdominal cavity.
The book lists the 5 F's for a big belly.
Fat, fluid, feces, flatus, and fetus.
Always rule out pregnancy. Okay, before we move on, we have to talk about the pancreas. Case 20.
Pancreatitis.
This is a true medical emergency. The pancreas is full of enzymes that are designed to digest a steak. In pancreatitis, those enzymes get activated inside the organ itself.
So the pancreas starts digesting itself.
It literally does. The pain is often described as the worst pain a person has ever felt. Severe, central, boring right through to the back.
And the main causes.
Gallstones and alcohol. The GA of pancreatitis. Okay, part 5. Functional disorders and nutrition. We mentioned IBS earlier. Case 23, Lisa Pike. How do you diagnose something that's functional? If all the scans are clean, how do you know it's not just psychological?
We use something called the Rome Third criteria to make a positive diagnosis. It's not a diagnosis of exclusion anymore. It validates it as a real disorder of the gut-brain axis.
What are the criteria?
You need to have recurrent abdominal pain for at least 3 days a month over the last 3 months. And that pain has to be linked to at least 2 of these 3 things. 1, it gets better after a bowel movement. 2, its onset is linked to a change in stool frequency. Or 3, its onset is linked to a change in the stool's appearance.
So it's all about pattern recognition.
Exactly. And for many patients, just giving it a name and telling them it's not cancer is often the most therapeutic thing you can do.
Finally, nutrition. Case 21, anorexia nervosa. The book highlights a very specific danger during treatment called refeeding syndrome.
This is a physiological trap, a very dangerous one. If you have a patient who's been starving and you suddenly feed them a big carbohydrate load, you can kill them.
Wait, why? You'd think food is exactly what they need.
When they eat, insulin spikes. Insulin's job is to drive electrolytes, especially phosphate, into the cells to make energy. But a starved body has no phosphate reserves. The level in the blood just crashes.
And no phosphate means?
No ATP, no cellular energy. The heart muscle runs out of fuel and stops. You have to refeed incredibly slowly and monitor their electrolytes like a hawk.
That's a critical point. Okay, let's wrap this up with a little review exercise. Part 6.
Let's test the toolkit.
All right, here's a scenario for you listening. You're a general practitioner. A 55-year-old man comes in. He's got new indigestion dyspepsia for about a month. And he mentions sort of casually that his belt feels looser and he's probably lost about 10 pounds. He asks you for some stronger antacids. What's your move?
Do you write the prescription or do you make a referral?
Think back to those alarm symptoms we talked about.
The answer is an urgent referral for an endoscopy.
And why? Justify that.
It's all about risk stratification. You have a patient over the age of 55 with a new symptom, plus a clear alarm symptom. unintentional weight loss.
That weight loss is the game changer.
It changes everything. If you just give him antacids, you might soothe the pain of a gastric cancer while it's growing. You have to look.
Wow. So we've gone from swallowing issues through the acid of the stomach down to the shag carpets of the intestine and into the chemical factory of the liver.
It's a huge system. But the takeaways are clear. You have to listen to the history. It tells you the location. Respect the red flags, weight loss, blood, anemia, and try to understand the mechanism. Is it a blockage, a pump failure, or a chemical imbalance?
And I suppose realize that so many systemic health issues show up in the gut first.
Absolutely. It's the engine room.
Yeah.
If the engine starts sputtering, the whole ship is in trouble.
So next time you have a tummy ache, maybe have a little more respect for the complexity down there. Just maybe don't diagnose yourself with anything too exotic until you check the Rome Third criteria.
That is very sound advice.
Thanks for joining us on this deep dive into gastroenterology. Stay curious, and we will see you next time.